Okay, well, welcome to this symposium. And I'm Philip Pearl. I'm the Director of Epilepsy and Clinical Neurophysiology at Boston Children's Hospital and William Lennox Chair in the Department of Neurology and Professor of Neurology at Harvard Medical School in Boston. And I've had an interest in pediatric neurotransmitter disorders a long time. And we have an exciting panel of folks that I'm going to ask to each introduce themselves, kind of like I did, where you're from, what you do a little bit, and then we'll just kind of talk about this disorder. And I'm really so pleased to have this panel of experts from all over the world, from what I can tell. So in alphabetical order, we have Dr. Irina Anselm, who's here with me in Boston, at Boston Children's Hospital, and Professor Wu, who I'm looking forward to what you're going to contribute, because I think that's going to be sensational. And we also have Dr. Warren Marks and Dr. Jennifer O'Malley. So, Irina, can you go ahead and give your introductory bio for this?
Sure. I'm Irina Anselm. I'm a child neurologist. I also work at Boston Children's Hospital. I have special interest in neurometabolic disorders, and over the years I followed several patients with AADC deficiency. I'm a director of a mitochondrial program in our department and a co-director of neurometabolic program, and I'm an assistant professor at Harvard Medical School.
Excellent, thank you. Professor Wu, tell us where you are and something about your experience with AADC deficiency, which I know is remarkable.
Yes, thank you. My name is Wu Liang Hu, and people used to call me Paul. So I'm Paul Hu. It's quite easy. So I'm a professor in pediatrics at the National Taiwan University, Taipei, Taiwan. So starting from a geneticist, pediatric geneticist, starting from IEM, I will say PKU, but in Taiwan, we have a special kind of PKU. It's a cofactor deficiency. It's a tetrahydrobacterium deficiency. So I got involved in neurotransmitter deficiency. Actually, it's very, very long ago. And then we discovered that in Taiwan, we have a population of patients with AADC deficiency. Then we try to develop a treatment for those patients. So I'm very happy to share with you my experience in Taiwan. Thank you.
Thank you. We will go there for sure a little later in the hour. Okay, Dr. Warren Marks, go ahead and introduce yourself to us.
Thank you, Peter. So I'm Warren Marks. I'm a pediatric neurologist and director of the movement disorder program at Cook Children's Medical Center in Fort Worth. I did not start off in movement disorders. I actually started in the neuromuscular world and actually traversed both worlds. I see both the MDA patients and the movement disorder patients along with my colleagues. Our movement disorder program actually developed out of a rehab program. From there came a spasticity program and the realization that a lot of what people called spasticity was really not spasticity at all, but dystonia. And from there we evolved from just doing spasticity to an advanced dystonia program with the really the first pediatric program dedicated to deep brain stimulation in the United States, which we've now been doing for almost 15 years. I have a long-standing interest in neurotransmitter disorders. I gathered them out of almost default from the group. They ended up in my lap, and I developed a pretty good friendship with the neurotransmitter group in Atlanta over the years, and have been seeing these patients for a long, long time. In all those years, I have to admit, there are precious few patients with AADC that have really come to our doorsteps. So I think this will be interesting to find out how common this really is as the treatments are developed, and we are able to use that technology to move into other areas.
Right. Okay, thank you. And Dr. O'Malley, please go ahead and tell us about your bio and your background.
Thank you so much, Dr. Pearl. I'm excited to be here with all of you. I'm Jennifer O'Malley, and I'm an assistant professor at Stanford and Stanford Children's. I'm a child neurologist, and I specialize in pediatric movement disorders. At Stanford, I'm the co-director of our spasticity clinic, as well as our pediatric DBS program. And I'm very involved in resident education. So this topic and increasing awareness and knowledge about neurotransmitter disorders like AADC deficiency is near and dear to my heart. And I'm excited to be a part of this panel.
Okay. I can remember Keith Hyland talking about this at a neurotransmitter disease symposium. I was involved with organizing at the NIH when I was in Bethesda in Washington. But it turns out Keith, who's at Medical Neurogenetics in Atlanta, described this condition back in 1990 with Peter Clayton, in whose lab he was working. And of course, Peter Clayton, very famous neurometabolic pediatrician at the Great Ormond Street Hospital in London, where the statue of Peter Pan is in front. If you ever get to go there, I had a visit there before the pandemic, so I was able to go and give lectures, and it's a really cool place. So they described the disorder in two twins, two identical twins actually, and they were doing CSF neurotransmitters. And at the time, their focus was on disorders of tetrahydrobiopterin synthesis and recycling, which are also very rare. But they figured out that these twins had very low CSF HVA and 5-HIAA, and did enzymatic analysis as well, including from liver, and documented the first cases identified of AADC deficiency. I remember in medical school learning about dopa decarboxylase with Parkinson's disease, and now it turns out really the enzyme is aromatic amino acid decarboxylase, AADC. So we're talking about the same enzyme, but of course it involves not just the dopaminergic line, but the serotoninergic line. So to me, that's when it was first identified, and it's still ultra rare. And I still rely on Keith's lab to send neurotransmitters. It's not done that many places in the United States. We can send neurotransmitters to that lab. We can send them to the Baylor lab in Dallas. And I'm not really sure where else does them in the United States, but maybe Dr. Wu will tell us how they make the diagnosis in Taiwan. How is it done in Taiwan? Of course, it's very rare in the United States, but it's not so rare in Taiwan because of the founder effect. So can you talk about
Yes.
How you make the diagnosis in Taiwan and how common use it is there?
Yes, I think for the diagnosis, clinical recognition should be the first step. But certainly in the past few years, we also developed a newborn screening for this condition. So I'm very happy that you mentioned Dr. Hyland, because in my clinical trial for the 10 years, we sent every CSF samples to his lab. So that is the kind of the basis of the diagnosis. Yeah. But certainly clinical is still rare in Taiwan. So clinical recognition is very important. Actually, I think at a later time you will share your experience too. I think those children do have some very special clinical manifestation. I always tell other doctors that once you make one diagnosis, then it's not too difficult for you to identify the second patient. But in order to facilitate the diagnosis, so we can have a lot of suspicious cases, but how to confirm to that if you need a lumbar puncture CSF for every suspicious patient, that will be a lot of work. So over time, we developed some convenient, easy, quick assay. It's the 3-O-methyl dopa assay. Because we are those biochemical newborn screening laboratory, so it's very easy that a few years ago we developed an assay. It's a tandemized assay specifically for this methyl dopa compound, and that this compound is very specific. It's only like a two disease. It's AADC. The other is another one, it's POPN, that will cause neonatal seizure. There will be a third condition that you take level dopa. Yeah. So just recently, we found that actually in newborn screening, it's quite easy. I don't know if you know the newborn screen very well, because we do acylcarnitine for every child all over the world, almost all over the world. And the recent method for acylcarnitine profile, we call this non-derivative assay. So we just elute the spores in buffer, and then we try to see everything as many as possible in that elute. Then we found that we can see this is free methyl dopa in the elute. So now we routinely check the compound in DBS in every baby, but certainly we need a second tier assay put on an LC to confirm that. So I don't think it's so difficult now, but certainly molecular and the CSF is the method for complementary diagnosis. Thank you.
Okay. Well, you've come a long way adding it to newborn screening. We haven't gotten to that point. You know, what we could do is we could have our other speakers tell us what question you'd like to choose. But I'm just going to start off to ask Irina, because I know Dr. Anselm has some long experience with this disorder. I'm not really sure how, much Dr. Marks and Dr. O'Malley have been able to see this disorder, but we're going to ask you about treatment of movement disorders. But Irina, why don't you go ahead and just tell us about your experience with AADC deficiency and managing it, any insights you have?
Yeah, so my first case was actually is 1998, and I remember I received a phone call from Keith Hyland. He was so excited that there is yet another case that is uncovered, and that was actually in a 17-year-old young man who was not diagnosed appropriately for his entire life and suffered from all complications of AADC deficiency with ocular gyrate crisis, dystonia, and so on. So, and then I had two more cases that I inherited from other neurologists, and I still follow this already adults. They're both 25. And then I think there is another case, Phil, that we share, a child from Saudi Arabia, right? So yes, condition is rare, but of course it's very frequently is undiagnosed or misdiagnosed, and we can talk about that. We don't know the incidence or prevalence of this condition, but there are studies that estimated that the predicted birth rate is from about 1 per 32,000 to 1 per 182,000 births, depending on the country. So which gives the prevalence of this condition in the world to be around 1,800. And so, but there are only about 130 cases reported in the literature. So we can conclude that many cases are undiagnosed, and maybe some are not reported. But yes, condition is definitely rare, but there are definitely more cases that we know about.
As far as the management, I don't know what you think about the medical management. I've had some success with dopaminergic agents, MAO inhibitors, and pyridoxine, but that success has been in the milder patients. And there are milder patients. There's a spectrum to this condition. I don't know if you see that in Taiwan, Dr. Wu, but there are some, but the typical case is so severe that the medical management hasn't made a whole lot of impact. Let's ask Dr. O'Malley, tell us about your experience with AADC or what you wanted to add in terms of movement disorders. I have to say their movement disorders are prominent, especially the ocular gyrate crises.
Yes, thank you. I think that this is one of those disorders that is so rare, but yet you don't want to miss it. And I think of all of the different diagnoses that we consider sort of the CP mimickers, and AADC can certainly fall into that category. And the presentation of these children in infancy isn't necessarily all that specific. So it makes sense, as Dr. Anselm was mentioning, that a large number of cases are probably as of yet undiagnosed. So when I think of this disorder, I try to think of this on my differential for any infant who has hypotonia of undetermined etiology, for a baby who maybe was a full-term baby with a normal birth history, no clear evidence of birth injury, but is profoundly hypotonic and failing to meet developmental milestones. AADC deficiency, amongst other disorders, is on my list of things to consider. And as Dr. Marks mentioned, I think for many of us in movement disorders and in child neurology, sometimes you get a patient sent to you with a chief complaint of spasticity, and then you have the chance to examine the patient and get the history, and you say, this kid doesn't have any spasticity at all. Instead, they have dystonia, or maybe they have a mixed movement disorder. And so I think when you're in the position to meet those children, we really have to be on the ball and think about reevaluating the diagnosis. Is a diagnosis of cerebral palsy really the most accurate? Is that as finely tuned as we can get for a diagnosis for these children, or could there be something else? And I think Dr. Anselm also mentioned some of the hallmark features like oculogenic crisis, or excuse me, oculogyrate crises can start to give you a clue. But again, it doesn't necessarily mean it's AADC deficiency. So I think in my experience, as I've learned more and more about this disorder, I'm testing for it more frequently with a fairly low hit rate. But I think it's an exciting time right now because we have the ability to test for this. We have the ability to learn more about it and start identifying additional patients. And as we all know, there are really exciting treatments on the horizon for these children. So while historically we've been limited by just symptomatic treatment using medications to control the movement disorder features or other neurologic problems associated with the disorder, I think really looking forward, thinking about some of the treatments that we have on the horizon are potentially really big game changers for these kids. So it's a really exciting time to
That's right.
be talking
Absolutely.
about it.
So, Dr. Marks, can you tell us about your approach to the CP mimic, a child who really has no etiology? They present with some movement disorder. What are the red flags that might make you think of a neurometabolic disorder, how you approach these children, and any other comments you want to make about how you intervene?
Sure. So I, like Dr. O'Malley, I have a very low threshold for testing. Even in children sometimes with a typical history for CP, the preemies, if their picture's not quite typical, we have found now a number of kids with disorders that mimicked their CP, and it really wasn't their prematurity that was giving us all the difficulty. I think that's especially true when you're finding much more dystonia on your exam than you're expecting from the typical preterm infant. Surely with AADC, I think that the things that really trigger the thoughts of AADC are the children who have dysautonomia at an early age. Dysautonomia is a relatively common problem even in the CP population, but this early dysautonomia in a child who's hypotonic, you may or may not see the oculogyrate crises, and most of the time they're mistaken for seizures when you encounter them anyway. And so it may not be the movement people that get a hold of them first, it may actually be the epilepsy doctors that are seeing them. Usually what happens is they'll end up getting a video EEG and they're not seizures, and then they call you and say, hey, there's having these eye movements, these are not seizures. What's going on here? The problem is that even in the children who look like, and I've seen now a few of these who look like they really ought to be pretty classic AADC, they're hypotonic, they're dystonic, they have oculogyrate crises, they have early infantile spasms, they have bad seizures, and their neurotransmitters are definitely abnormal. But then you look at their brain and the basal ganglia are all beat up, and there's no real history to go along with it. But that really complicates the picture. Because you really shouldn't have the anatomic abnormalities in AADC, at least in the basal ganglia. This is a biochemical problem, not an anatomic problem. But I think if you keep those things in mind, and I think using the testing like this, the CP mimic or the CP spectrum disorders panel that's out there now, we're finding lots of things, not as much AADC as perhaps we would think we would find. I mean, I think I picked up one carrier, again, anytime you see the ocular gyre crises, you have to think somewhere in at least the neurotransmitter pathway, whether that's in tyrosine hydroxylase or anything down below that, then you have to think of it. It's not obviously common in straightforward DRD or dopa responsive dystonia, but any of the further down processes from tyrosine hydroxylase on, you really need to keep those in mind. But even with all of that, there were mimickers. We've had one that multiple centers thought had tyrosine hydroxylase deficiency and had all the classic biochemical findings to go along with it, and didn't, had something completely unrelated. So, you know, even when you think you have it, you still may not have it. So having the availability of doing the enzymatic assays is actually very helpful to sort that out.
Very interesting panel you mentioned, CP mimic panel. I'm sure you're talking about a gene panel. Can you tell us about some of the diagnoses that you have uncovered using that panel that you hadn't suspected?
Sure. Well, and some that perhaps we did suspect, but I've had a teenager sent to me with a movement disorder that had Rett syndrome. We picked up several kids with Angelman's. That may be one of the more common things that we pick up. We've picked up actually, we picked up 2 or 3 kids with Rett along with the Angelman's kids. We picked up there are a multitude of these rarer genetic disorders that you can get to, but this panel has made it so fast that I think in some ways the genetic panels are actually changing the paradigm. And Dr. Wu talked about, and particularly in Taiwan, it's probably true because you have enough of this that you can look at the symptoms and think this is what it probably is. But with a low threshold for testing, sometimes you get the testing and your paradigm is, okay, well, I have these genetic abnormalities. Does that actually fit what I'm seeing in the child? So it has kind of reversed our thinking on how we're approaching some of this.
Very interesting. Thank you. Thank you. So, Professor Wu, why don't you tell us about your approach to AADC? I think you probably have the most experience among us in terms of the gene therapy. Can you go ahead and tell us how you manage these patients, how you make that decision, when to go forward with that, and your experience with it?
Yes. I think we experience a quite large number of cases. I do have 1 or 2 minor cases that they respond to medication very well, so we just leave them there, so just don't touch them. But for typical cases, for the infants, it's really very, very difficult. So in my early time to manage those patients, we use the dopamine agonist and also other medication. I will say for the most severe cases, we saw more complication from the medication rather than efficacy from the medication. Yeah, so it's you see the nausea induced by those agents. This is also very difficult. But certainly, recently we used a patch that from Parkinson's disease we call this Neupro patch. We think that medication is very easy, the same efficacy as the other oral medication, but it is much easy. So we make diagnosis, but the treatment, the gene therapy actually is because of the surgery that we cannot do that in very young. So the youngest patient we can do is like 18 months. So for everyone that we discover before 18 months, for example, those are several children that we discover at birth. So we need to carry them on for 1.5 and 2 years. So during that period, that's a very difficult period. But then we got a chance to observe the real clinical causes of those very severely affected patients. Actually, many of them, they are born as a normal infant. Yeah, so as a young infant, especially before 3 months of age, they just look normal, feed normal, and not much special symptom signs. And then after that, around a few months of age, then you saw those abnormal movements, and feeding can be more difficult. And then this OGC tried appear just gradually. So those symptoms that will become very prominent around 1 year of age, and we will try to manage those patients with medication, just as mentioned. Just currently we use a Neupro patch. We may give some of the vitamin B6 for folinic acid, for example. We try to help the feeding of those patients, try to keep their weight. So we really have got a period of time, at least a few months, that we can try everything to help those children. Then when they reach the age that we can perform gene therapy, it's very clear that if it is necessary to do such a still novel and invasive procedures. Yeah. So as I said, I will have one patient that we treat with this protocol, and then he became very well, went to normal school, and then we will just skip those patients. We will focus on more serious affected patients. But certainly the gene therapy is not really a cure, but it's just effectively improve the symptom. And then after gene therapy, we restore dopamine. Then there's a very long way of rehabilitation that will be necessary for their treatment.
Okay. You know what I'm going to do? I'm going to step back here and make some summary comments that might be helpful, which is just so everybody's on the same page. We're talking about a rare but pretty exciting, as Dr. O'Malley has said and Dr. Anselm has said, because this newly available gene therapy, neurotransmitter disorder. And as emphasized by Dr. Marks and Dr. O'Malley, in the movement disorder world, kids are seen with CP, but there's no clear explanation. The imaging may be unremarkable. Dr. Marks made this really interesting observation that if the basal ganglia look very injured, it's probably something else. But if they don't look so injured on imaging, this really could be AADC deficiency. Well, what is that? That's aromatic amino acid decarboxylase deficiency, which is a really crucial enzyme to synthesize dopa, and dopamine and serotonin, because it converts L-dopa to dopamine and converts 5-hydroxytryptophan to 5-hydroxytryptamine, which we call serotonin. So this disease presents at a few months of life, as Dr. Wu was saying, with really severe hypotonia, but also dystonia and ocular gyre crises. I've seen some children present with hypoglycemia because they can get into real trouble with gluconeogenesis. The first patient I ever had, the family was very concerned about their child, and they saw a news show, some TV special on dopa responsive dystonia. And they were absolutely convinced that their child must have this wonderful treatable disease where you can give L-dopa to somebody who's been dystonic like a pretzel for decades, and you give them a whiff of L-dopa and they just recover. In fact, I'd like to hear if our movement disorder people have any special expertise in that. So they came to us saying, oh, we want to try L-dopa, and it turns out the child had AADC deficiency, but it's actually done pretty well with medical therapy. On the other hand, the kids I've seen present with hypoglycemia and horrible hypotonia to the point of paucity of any voluntary movement, they really don't progress. They have very bad outcomes. They need gastrostomy tube feeding. And now we have this gene therapy available, which is in an investigational stage in the US. A question came up on the forum: how does one enter clinical trials for prospective AADC deficiency treatment? You could go to my favorite website for this, which is clinicaltrials.gov. And on there, you will find trials of gene therapy for AADC deficiency. There are actually two ways it's being investigated in the United States. One is injection into the substantia nigra, where dopamine producing cells are, and one is injection into the putamen, where dopamine has its role, its synaptic role into those cells in the basal ganglia. And we actually don't really have the studies or the data to say one different than the other, but they're different approaches. Yet it's just so promising to be able to have AAV mediated, in other words, adeno-associated viral mediated gene therapy available for this, as well as more and more neurometabolic diseases. So I just wanted to give kind of an overview and then call on each of our speakers just to say, what from your perspective would you add to that? What has struck you about this disease or about kids who present with these kinds of symptoms that you would add for someone listening to this who could be a family or could be a pediatrician or a child neurologist or other physician involved in neurodevelopmental disabilities? Irina, go ahead.
Yeah, with my experience, especially with this 17-year-old boy who was diagnosed at age 17 with AADC deficiency, he was having all this horrible oculogyric crisis and dystonic spasms, and he was untreated for that. And so I think the uncertainty of what's going on with children is so painful for the families. So I think that it is so important to diagnose them. But I agree that some of the, even if diagnosed, more severe cases, not so amenable to treatment. So I had some success with dopamine agonists with milder cases, but with more severe, we just see side effects with dyskinesias and so on. And so it is really, really difficult to treat. And so the whole hope is in gene therapy, about which we're going to hear more. So that's the one thing. And again, when the diagnosis is made, these families, they start belonging to certain groups and communities, and they find more and more from other families about it. And I think that that's very important. The other thing is, like, we think of this condition as being non-progressive from biochemical standpoint, but yet over the years, this patient developed so many complications. My 17-year-old patient actually passed away, and we still don't know why exactly. We suspect from cardiac arrest. And then another patient who is 25 years old, she developed such severe scoliosis that she required to get tracheostomy because of restrictive lung disease. So again, over the years, more and more problems may happen to these patients if they go untreated. So I just let other people do.
Thank you for sharing that. Some of that's heartfelt testimony there. Thank you for sharing that. Jennifer, what can you tell us? And I'm also thinking about something that Irina raised, which is long-term complications in movement disorder patients. So go ahead.
Absolutely. I think one of the things that has been most impressive to me about AADC deficiency is the variability in presentation. I think we often think about the most severe cases, but as was discussed already today, there can be a high variety of severity depending on the type of mutation a patient has. And so I think for me, that variability translates into having a very low threshold to test children, even if they don't necessarily have the most severe clinical presentation, because as has been mentioned, the high impact of successfully diagnosing this disorder, I think is very evident, especially as these new emerging treatments are becoming more and more available. So I think from a movement disorders standpoint, the first step is recognizing these kids and getting them diagnosed, and then really starting to think about what can we do beyond just symptomatic treatment with medications, and then how do we integrate medications with gene therapy to really optimize and maximize function for these children. And I'm curious to see, as the field moves forward, if sort of our threshold for who to treat changes, because as Irina was just suggesting, these children have really profound implications for development. And I'm very movement centric as a movement disorder specialist, but even if their movement disorder isn't the worst part of their presentation, they may really benefit from better control of the dysautonomia, or have really potentially profound effects on improving their development with treatment. So I wonder kind of what the future holds, and how we will address who to treat and who not to treat as we think about those issues.
A lot to work out there. Warren, you said that you're closely aligned with physiatrists, which makes a lot of sense. And I'm wondering if you have any comments on who treats these kids, who sees these kids. Do you have a system? You're in Texas with a rapidly growing population, is my understanding. Do you have a system there of centers of excellence? How are kids triaged and seen, at least in your area, if not more broadly? Do you have any? Can you make any comments on that?
So it's a really complex issue. Our group of neurologists actually made the decision to incorporate physiatry into our group. So rather than competing against them for procedures and the way we're managing patients, we think it made much more sense to get in, sit on the same page, and kind of divvy up the management so that we both learn from each other. The physiatrists are learning more of the neurodiagnostic skills from us, and they're helping us with our management skills. We all do a lot of the procedures. We all do medications. All the people in our movement group do chemodenervation and things like that. And some of us have done our own bracing over the years. But it's nice to have people that are really focused on that. And so I think our skills are probably more in the focus more on the medical and surgical management. But we do try and take a holistic approach to how we treat neurologic disease, not just this. Actually, one of my epilepsy colleagues and I, many years ago, actually wrote an article on the habilitative approach to epilepsy management, of thinking more than just seizures, thinking in terms of the whole child and the whole family. And yes, seizure control is important, but there's more to it than just seizure control. And that's probably even more true in movement disorders. Sure, controlling the movement disorder is very, very helpful in CP, but it doesn't solve all of their problems, and it doesn't help all the family's problems with the progressive skeletal abnormalities that you can see, the respiratory involvement, the feeding problems, and then all the social and economic implications of all of that, which are huge for families. It's very hard to work when you've got to be home taking care of a child who's dependent on you for everything. And so this has lots and lots of implications. I don't know that we in the United States even have done a great job of really developing true centers of excellence that everybody's comfortable referring to, but that clearly is the way to go for rare diseases. You don't need 25 places trying to do gene infusion therapy for the 6 children a year that we're going to see. Nobody's going to get good at that by doing that, and we're not going to do a very good job. And so we need to recognize that there is a real need for places that can do these highly specialized treatments, and then not everybody needs to do everything.
Really good points. Really good points. It reflects a lot of experience in the real world. So, Paul, how about if you tell us about your experience with gene therapy?
Yes.
What your experience is, how the patients have done long term. Is this really one and done? I mean, do we think that one-time gene therapy is going to take care of the kids, or are you going to need repeat doses? I don't know. Can you tell us? You've got more experience in Taiwan than we do in the USA.
Yes. Yes. As you said, this is a one-time treatment. So once they receive gene therapy, they don't need to have any medication. Yeah. So if this is a good case, yeah. So I want to starting from gene therapy first. Gene therapy is very new treatment, so we are very excited in many diseases that they are not treatable in the past time, now get a chance of a treatment. But we also notice a few of the downside of the gene therapy, the complications, and they can have a liver cancer, they can have a leukemia, they can have acute liver inflammation, so those dangerous things. But in my gene therapy, that is very simple and safe. So we just put a little bit of the AAV2 into the brain. So there's no risk of cancer because of the neuron that uptake the virus. They don't divide essentially. And there's no or not much immune response in the brain. So we don't see any of the long-term complication of that treatment. So the reason that we start from the most severe fatty patient because of this is a new treatment. Usually we just target those that they don't have other choices. Yeah. And also this a good way that because the patient that I treat with gene therapy, they don't move. Essentially, they have very severe hypokinesia, and when they move, they have dyskinesia or dystonia or OGC. So, and then just a few weeks after gene therapy, I will say starting from 4 weeks, and the movement, the uncoordinated movement or dyskinesia will peak at 8 weeks after gene therapy. So it is so simple that if you do a right injection, we never miss one, because when we inject the putamen, it's a little bit big and easy. So if you do the right injection, then a few weeks later, you just try to observe the movement from those children. For the older patient, they seem to starting from the fingers, they move a little bit. And for the younger kids that are 2-3 years of age, just few weeks after the gene therapy, they move all around the body. But certainly, initially those movements, they are not functional. So you are expert in movement disorder. So I try to learn that the movement, we say functional movement must be obtained from learning. Just like a newborn baby, at first they move, they have no function, then they after practice. So in my patient after gene therapy, they just start to move, and then they will try to control their movement a little bit by little, and try to make that purposeful movement. And we need a lot of training for the trunk, for the body, because that are difficult parts of the movement. So we have a very sophisticated training program, including the gait trainer, and swimming is asked them to move the body. And we sometimes we say that in a good responder. So after gene therapy is the day 0, like a newborn baby. So it's 1 year after gene therapy. If we are lucky, the child will have a development of 1 year of age. But not everyone can achieve that goal. So I would just say that this is new hope to those patients, especially severely affected. But certainly, there's still not a cure. Working is only in a small portion of the patient, and speak is only in several patients. But once the treatment get approved, for example, in the United States, I think because this is very safe, this certainly can be applied to more patients. So even those that respond to medication, those medications are not easy. So you'll get trouble for missing those. The gene therapy is just once and for all. Thank you.
Right, thank you. And we certainly think that injection into, say, the putamen is going to be a lot safer than an intravenous kind of gene therapy, or
Yes.
even in the CSF, which could have more widespread effects, as you mentioned at the outset, with liver inflammation and cancer, that it should be much safer. Well, we are down to the last 10 minutes, so this gives everybody about a chance for about a 2-minute closing statement to share any words of wisdom you'd like to share with our audience. So think about what a message you'd like to impart for closing. Irina, can you go ahead, please?
Well, I think it would be very important for us physicians who are involved in care of these patients or movement disorder physicians to sort of spread the word about this condition and educate child neurologists about it, because otherwise these patients will continue to be missed. I think that in the past, we mostly relied on the diagnosis on CSF analysis, and we still do that, and we still send samples to Keith Highland, but now genetic tests have become far more available from panels and whole exome sequencing. So I'm really hopeful that we'll see more patients being diagnosed and hopefully ultimately treated with gene therapy.
Very nice closing statement there. Jennifer.
Yes, I think like most things in medicine, education is key. And so for me, it's really making sure that we are continuing to learn ourselves and sharing this type of information about disorders that are very rare and little is known about them, like AADC deficiency, making sure we're teaching our residents and fellows and colleagues about these types of disorders, especially as treatments are emerging. I think for me, that's one of the things that I really enjoy is helping teach learners that when you see the hypotonic baby, think about where is that hypotonia coming from, and could it be a sign of low dopamine? And I think that can really change the way we think about what is typically a very common sort of neurology consult, a baby with low tone, and making sure we're teaching our learners to consider neurotransmitter disorders in that differential. That's going to lead to more testing and more identification of these children and potentially earlier intervention, which it's, as we've all discussed, is really the goal here, so that we can help these kids live to their fullest potential.
Well said, and you're showing your educator's hat there. You're bent toward that. Warren, how about a closing statement from you?
So I would echo some of what a lot of what Jennifer just said. When I see families in the office, when I have students with me teaching, I try and talk to them about a pragmatic approach to how we do things. There are so many tests out there and so many things you can do, that my approach is look for things that are treatable first, and we can worry about everything else later. And, you know, AADC and the neurotransmitter deficiencies in general are on the list of those things that are treatable, for which you can really make a big difference. So you have to keep them in mind. I do think that the idea of early recognition is really, really important. We know from the world of dystonia that the longer period of time a child spends with dystonia, the worse their overall outcome, not only from the motor standpoint, but from the social, psychological, family standpoint. The longer they spend with dystonia, the worse it is. And unlike the adult world where you have dystonias that start late, where you can intervene earlier, these are children that are often born with dystonia or have dystonia very early after birth. So we're behind the 8 ball before we start. And even with this gene therapy, you know, you're still stuck with the fact that you can't treat them till they're 18 months or 2 years of age. And this is not unique to this. Our whole management of spasticity and dystonia is delayed in proportion to what happens to the muscle. All the time we're trying to figure out how to make your tone better. Permanent changes have occurred to muscle that we won't be able to reverse, and we know that. And then there's the problem that Dr. Hu brought up, that, you know, it doesn't always work. And we know that from the experience in the neuromuscular world, that gene therapy is not always the final answer, that there are those children for whom response is incomplete or not what you would think. So I just think that the whole key is early recognition and getting the word out there.
Terrific. Paul, any closing comments from you?
Yes, first I'm very excited to talk to a panel of experts in this disease. Otherwise, especially in my gene therapy talk, there will be nobody know this disease, so it's sometimes very difficult. Yeah, and second, I am a geneticist. I'm not a neurologist, so I always try to find an easy way to help doctor to make diagnosis. I run a big lab, so we run high-risk screening program. So we do test fast and cheap. But for this disease and for many rare disease, and I think the molecular diagnosis is just open another page of a diagnosis. I will try to echo Dr. Marks that if you meet a very severely affected children, but when you see the MRI, it's normal. It's a perfect normal MRI, and then you just go for whole exome sequencing in my hospital, and that for good chance that you can have a diagnosis. And finally, I think the experience that I have in Taiwan is very narrow. So the patient spectrum I treat is quite a monotonous. So it's a narrow spectrum. And I also very excited that the gene therapy will be spreading to other location that more patients will be treated, and then we're very happy to know the treatment outcome of every patient in the future. Thank you.
Thank you. You know, I kind of explain AADC deficiency as a form of infantile Parkinson's disease. In Parkinson's disease, you have degeneration of the dopamine producing cells. In this disease, you can't produce dopamine or serotonin. If there's a way we can deliver it medically or through gene therapy, which is bound to be more efficient and work better, that's exciting. And these closing statements that this disease is easy to miss, that we have to educate ourselves about it, and our trainees and other physicians and families as well, is all part of it. And that's been an important part of everyone's closing comments. I want to thank our panel. It's been a great joy to be here with you and discussing this important area. So thank you very much.